Welcome to the Hope Podcast. My name is Jonathan James, and it is my pleasure to be with you today to talk more about women with bleeding disorders on this episode. And we want to say a big thank you to our episode sponsor, Genentech, for providing a support to us through educational grant to make these moments like this possible. So today I'm super excited to do a deep dive into really the history of where all we've came from, but more importantly, truly an expert in the field, Dr. Tamuella Singleton. It is great to have you with me today.
Yes.
Thanks so much for joining for the Hope Podcast.
Yes, I'm super excited to be here.
Yeah, well, I just absolutely love every moment that I get to spend with you. You're just such a hero in my eyes. I know so many people in the community just have so appreciated not only from the patients you've treated. We've heard a lot of that and about so much great feedback from that point, but also just your leadership, because you provided so much leadership for the community as a whole. But maybe somebody's listening right now and has no idea who you are. And so tell us a little bit about where you're from.
Absolutely.
And then your journey about becoming a hematologist.
Well, first of all, I have to start by saying I feel the same. Right? Like that just kind of intense respect, admiration, love for, care for everyone in the community. I feel the exact same, so it's nice to kind of have that relationship, I think, as a physician. I don't know that I expected that it would quite be like that, but it's really a once in a lifetime kind of experience and journey. So I'm so grateful.
Yeah.
So with that, we are sitting here now in Louisiana, right?
Yeah.
And so born and raised. I am from Louisiana, and usually when I travel, and especially when I start talking and I'm traveling, I get the head, turn like,
where are you from?
Where are you from? So what are you from?
Right.
Yeah, where are you from? So, and I usually say Louisiana, and they go, yeah. But I mean, originally, like, where are your parents from? And I would go, well, I'm actually from Louisiana for probably about 300 years. On both sides of my family.
Right.
Probably about 300 years. A few people came across on a boat, some voluntarily, some involuntarily. So, yeah, it's a little bit of a mix.
Right.
But I'm originally from Baton Rouge. I was born and raised here.
Awesome.
My parents, too, born and raised here.
Wow.
And when I grew up in Baton Rouge, we didn't have 100,000 people here. And I can remember my dad saying, how it was going to grow and what some of the plans were. And I'm like, yeah, like whatever.
Wow.
Yeah. But it was a much smaller place.
Yeah.
And I'm the daughter of two educators. My father was military in education, retired from the Army, and was actually my elementary school principal, to get that together.
Yeah.
So I was at home all of my formative, very early years before school with my grandmother, who was a teacher. And my mother was a kindergarten teacher in East Baton Rouge Parish for 40 plus years.
Wow.
So lots of education, right, kind of going on, and opportunities to read. I was told I was reading when I was 3. I went to McKinley Middle Magnet, Baton Rouge High, ultimately graduated from Lee High School. I grew up kind of right down the street, Stratford Place, Concord, Stratford Place.
Wow.
College Drive, Perkins Road area.
Yeah.
And I think being a physician was always in there. When I look back on it, I was glued to the TV as a very young kid when MASH was on.
Yeah.
I didn't understand what they were saying, but I wanted to see the OR scenes. I'm like...
Are they cutting on anybody?
Yeah, I was like, what is happening here? So, all of those kind of old movies. I didn't grow up with any physicians, and I certainly would never have imagined that I was going to be a hematologist oncologist. I don't think that I solidified, yes, I'm going to go to medical school, but I was very driven for some reason to go to Xavier University in New Orleans. I was determined.
Wow.
And very driven. And I think it was because this is sort of what I was supposed to do.
Yeah.
And that place is just a miraculous place.
Wow.
For me, it was a place where it's a historical Black college, but Catholic.
Oh, wow.
And it was a place where, and it was important to me ultimately, where God was present.
Come on.
And I had an amazing education where my instructors, they knew who I was. You know, they knew me.
Yeah. Yeah.
So they had expectations.
Yeah.
The support there, the way we supported each other. And every school has a personality. And I think Xavier had a very academic like personality.
Yeah.
At the same time, it was a very nurturing place. And when my parents dropped me off, they loved the fact that we didn't have co-ed dorms. There was no visitation. And there was a curfew. And if I broke it, they got a letter. You know, it was very serious. So anyway, I said all that to say I think my steps were kind of ordered.
Yeah,
So.
I love that. I love that. It's destined all the way from the beginning.
Yep.
You were such a. I know you to be such a science nerd in a million ways, and so I always love that about you. But you know, we've talked about this before about how you have such a great people connection, which is not always sometimes,
not always the case.
Yeah, sometimes the science nerd and the people skills don't go hand in hand. But how did you at some point during your journey, how did you come into hematology specifically? Because generally speaking, hematology and oncology both are very research oriented, and you find a lot of people that love to be in labs and not with people. So how did that part kind of happen for you?
Well, I think at my core, I'm a bit of a geek nerd. Yeah. Love science. Yeah. Kind of thing. I think the people loving kind of person in me, that's my mother.
Yeah.
It is 200% my mother.
Yeah.
Everyone at the Albertsons down the street, they know Miss Kristen Terry. Everybody. The whole store, like they know, exactly who she is. She talks to everybody in the whole store. I take her to a restaurant. If we go to Parran's right now, she's going to stop and try to talk to everybody. From the time we walk in, I'm like, oh my God, like, come on. Like, so I think I got that from her.
Yeah.
But the hematologist thing is a little bit of a long story. I'll try to abbreviate it for you.
It's okay. We got time.
I knew I wanted to go to medical school. Especially once I got to Xavier, I was very driven. I knew that was going to happen.
Yeah.
I was a chemistry major, and I remember I called my dad and I said, I think I've really truly committed that I'm going to go to med school. And he says, yeah, you're a chemistry major. Chemists make great money, Tammy. And I said, I didn't tell you I wanted to be a chemist. I told you I'm going to go to medical school, which I think he probably found kind of hard to conceptualize, his baby girl, going to med school. But I was very determined. I had an opportunity to go to many schools across the country and decided really honestly to stay at LSU because it was very inexpensive.
In-state.
It was in-state. Right. I had little to no tuition to pay.
Wow.
But when I tell you the education I got, at Louisiana State University School of Medicine in New Orleans and Charity Hospital is, in my opinion, second to none. Wow. Tried and true, tested.
Wow.
I was interested in research, though, very early on and sort of long before I really knew about the hematology thing. Mm-hmm. So I was attracted to residency programs in Miami. I went for a summer program and I was determined I was going to train in Miami. I was like, this is like New Orleans and Charity Hospital with palm trees. Like, I love this. This is great. Their medical center was phenomenal. And so I knew I wanted to go there. So I had opportunities as a med student to apply for kind of research programs, research grants. So I did. And in doing that, in receiving those grants, I called up the director of the pediatrics program, which I thought I was really interested in pediatrics. And he just so happened to be a hematologist.
Oh, wow.
And he was treating, his area of interest was sickle cell disease at the time. And so I said, well, hey, his name is Charles Pegalo. I said, hey, Dr. Pegalo, this is cold call. My name is Tammy Kristen Terry, and I'm a medical student in New Orleans. I have a grant. I would love to have an opportunity to work with you for the summer. Is it possible for me to, to meet you, to come, blah, blah, blah. He said, absolutely. And I spent 12 weeks with him. And as a result of that, I really started to like hematology. And two, my schedule was altered at LSU kind of because of that. So I sort of got the last pickings for something called a sub-internship. And there's a sub-I. Most people want to be on the floor with the younger babies. The adolescent floor was last. And the peds hematology oncology floor, I was told no one wanted that. And she said, the lady who was giving out the rotation, she said, well, no one wants that. That's just so sad. Those, little children suffering in their cute little bald heads. And I said, that is terrible. To myself, I said, why would you say that?
Right.
In my head, I'm saying this, right? And I said, you know what? I want that one.
Because nobody else does.
I was like, I'm not afraid to have it.
Wow.
And you think it's horrible, and I think it's probably not. And I want that one.
Wow.
And so I went. And to make this long story short, I did not expect to love it. I did not expect to fall in love with it, but I did.
Wow.
The residents I was with during that rotation, they hated it.
Wow. Huh.
And I was so excited to be there. Every time the attending would ask questions on rounds, I'm like, raising my hand. I know. And
I could totally see you doing this.
and eventually she would go, not you. But I loved everything about it. But what I found most inspiring about it, honestly, were the patients and the families.
Yeah.
I love the science and how interesting it was. And it was both hematology and oncology. It just seemed like the opportunities were endless.
Yeah.
It was so interesting from, again, a scientific standpoint, but the people.
Yeah.
I mean, it was just amazing. And so I was really upset one day about, some pair of shoes that got messed up. And, I spent my whole allowance on the shoes and I got really angry. And I went to work that day, went to the hospital that day thinking about that.
Mm-hmm.
And all I had in my mind, I'm in a bad mood. My favorite suede shoes got so messed up. I'm so upset about this. And I walked into a patient room. I opened the door. Good morning. And they turned and looked at me. And it was a mom and a daughter. And the Child Life people, they were in there painting her bald head green with yellow polka dots. And they looked at me and beamed and just smiled with this, the most pleasant, welcoming, oh, hey, Dr. Tammy, come on in.
Yeah.
And I looked at them and I went, I feel small. I'm so upset, right, about my shoes and this trivial thing. And this mom and daughter are in the fight of their lives. But yet they can manage to be positive and try to give something back to me that morning.
Wow.
And I just said, you know what? This is the space that I want to be in every day. I want to be surrounded by this kind of hope, by this kind of determination, this kind of love. I want to be in this space.
Yeah.
And from that day to this one, I kind of never looked back. I wanted to be a pediatric hematologist oncologist. I trained at the University of Miami for peds. I trained at Johns Hopkins and the National Cancer Institute for peds hemonc. I mean, the doors just kind of unfolded. Now, the coagulation thing happened in a similar way.
Okay.
I was on maternity leave. I had 2 children in fellowship. I was probably the pregnant fellow. And I don't want to put my program director on blast, but kind of, right? So he said, oh, well, you're going to be on track. You're going to finish everything on time. You shouldn't have a problem. He said, you have this 4 weeks that you needed to make up in the coag lab, but you can do something else if you want to. You don't really have to do that. And I said to myself, I don't have to do that? What are you talking about? I don't have to do that. What do you mean? That same response that I had with the lady, right? With that. And I'm like, you telling me I don't have to do that? Like, that sounds insane. Of course I have to do that. I'm going to do my rotation. And I insisted on doing my coag rotation.
Wow.
And because of that, again, the geek in me comes out and I had a ball.
Wow.
So my husband and I talked about potentially going home after fellowship. And I said, okay, well, let me call and see my old attendings at LSU. I'll call Tulane. I'll call Oxnard and say, hey, I'm a fellow at Hopkins.
Yeah.
I'm from New Orleans.
Yeah.
I think I'm coming home.
Yeah.
So as I'm training, are there any needs in the state and the city? Like, where are the holes? Could I possibly focus on something here, right, to serve a purpose in bringing it back home?
Yeah.
And the first thing all of them said was coag.
What? Wow.
Hemostasis, thrombosis, coag. And I said, how about that? I said, well, that's not a problem. Because I newly discovered that I liked it.
Yeah.
So I tried to do everything I can to go to the hemophilia clinic, like when I could.
Interesting.
To spend more time in the coag lab. And one thing led to another. And I can tell you other stories about Katrina and how, I met Cindy Lessinger and she took me under her wing from the moment I met her, Dr. Lessinger.
She's wonderful.
Oh my God. She became, my mentor and friend, and didn't hesitate. And then, I learned from Karen Wolf and, that entire team and Sue. My gosh, like those guys were amazing.
Yeah.
And all of the patients that I've had over the years at Tulane, that's who really taught me, right? All of the patients, the complicated patients coming from Alabama and Mississippi and Louisiana. And although I was training peds, I saw adult patients and I saw kids. Now we're talking about women today. And what I can say is I've had an opportunity in that journey to see the transition, but to also recognize like where we got it wrong and how we're starting to get it right. And I never talked about women or girls. We never thought about a woman or a girl, which seems crazy to me now.
Now, right.
I mean, it wasn't a thought.
Yeah, because traditionally it was always contemplated, even in the literature, was always contemplated it was predominantly a male disease, right?
But what's so interesting is for those of us who are scientists, right, we do understand the concept of lionization. It is a thing.
Wow.
So if you have two X chromosomes,
right,
one of them may not make up for what's absent on the other.
Right.
It's not strong. It's not
if you have
strong
an X
enough.
chromosome,
In other words,
you
right?
could be affected. Right. Exactly.
Right. So just because you have an X chromosome doesn't mean that you cannot and will not be affected by the X-linked disorder.
Right.
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 Again, these are
that
scientific.
Seems so obvious now,
but they're
25 years
scientific.
ago,
They're scientific concepts that we did not apply.
Interesting. Wow.
Right, directly to women. And I guess in all fairness, as we learn more about DNA and learn more about genetics, right, it became a thing. But when I think back, it was never a thing. We never talked about it.
Right.
We didn't treat them.
Right. Well, and I have to say too, like, I mean, it presents differently for women as it does men. But in essence, the root cause or the root problems are really still there, like either way. And so the fact that we're unfolding some of this more and science is catching up. I don't know if maybe the science was always there, but it's like we're starting to realize, oh my gosh, like there are people out there that could benefit. And there's a whole lot of things that I want to unpack in that. I feel like we have a lot to cover there. But
let's talk about it.
But one of the things that I think is a driver too is understanding, and it's not just this. And I'm learning a lot in this because I don't come from a science background, but having seen the crippling effects that I experienced as a child, you generally don't see women having crippling effects at 5 years old. There are some that have severe hemophilia. We've met a few in the community, but generally, and they do have crippling effects early on. But that doesn't mean that it's not present. And I think, we always kind of, and I know with a lot of the patients I talk to, it's like we always wish we kind of had one of those like diabetic, things that could tell you what your factor level is all the time. But that doesn't exist. And so it's kind of this idea of like, how do we manage that? And so questions that I don't think I've ever thought, or most of the people that I know have not thought about, that we're starting to think about now is, can factor levels change? Do they go up? Do they go down? Does that present differently for women as it does for men? You know, there's so many. What's really neat is to see this being embraced both from, and it takes kind of both, right? I mean, the patients need to ask the right questions in some ways to move the needle along, so that, you know, those who are making the decisions also can respond to those questions, and then simultaneously there's this aspect of, okay, you know, we've got to be educated on both sides, but there's another measure of it. It's like, okay, well, if there are problems, maybe with longer than normal menstruation cycles, I can't tell you how many women I've talked to that it's common for them to go 2 weeks and they just thought that was their normal. So just getting educated to the point and go, oh, this could be connected because your son or maybe some relative had hemophilia. There could be there's a reason why you're going 2 weeks instead of just 8 days or whatever. And so I just think that it's almost like the learnings and the understanding has kind of been there, but we didn't see the forest from the trees for a long time. Would you agree with that?
Well, yeah, and let's unpack that for a minute.
Yeah.
Right, and think about that. So when you're managing a crisis, right?
Totally different set of rules.
When you're managing a crisis, your concentration is on the crisis.
That's right. Absolutely.
Right? So if a house is burning, you're concentrating on putting out the fire in the house.
Right.
You do not have time to make observations of anyone who's standing around the house.
Right.
Even if the people around the house are also suffering or maybe even burned or what, you're trying to save the lives of the people who are in imminent danger.
Right.
So I think that to kind of maybe give all of us a break, the physicians, physician scientists, the community, you know, everyone, that for a long time in hemophilia care in particular, which is the center of bleeding disorders, right? Because the bleeding was so severe.
Right.
So if we almost have a bullseye and we're thinking about bleeding disorders, hemophilia would have been at the center with the number of patients, the severity of what was happening, right? And the center of the crisis.
Right.
So you focus on the crisis, which is the most severe patients first.
Right.
So even though someone who had 5% circulating factor 8 or factor 9 may have been suffering, it may have been pale in comparison to someone who had none.
Right. That makes sense.
So with few to little treatment options, too.
Right.
The hustle and the struggle is real, right? Because you're focusing on managing the crisis.
Right. And we had two of those. It wasn't just the fact that we identify, oh, there's a protein deficiency. This is a genetic mutation. We're going to give more protein.
It was the 1-2 punch.
It was HIV.
That's right.
And honestly, I mean, yeah, late 80s, 90s, HIV, but I mean, all the way up to what, 1995, hepatitis C is still pervasive.
Oh, yeah.
So it's almost like we had a 1-3 punch where there was like, you're dealing with multiple crises that are happening within a generation.
That's correct.
And so it's all focused on how do we stop the bleeding?
Correct.
Pun intended.
Correct. It's all right. Yeah. It was focusing on that crisis. So I think as therapies have evolved, right? As treatment options for HIV
we put the fire
have evolved, right? We put the fire out.
Right.
And so when you put the fire out, now you can turn around and start kind of surveying the damage.
Who else is in trouble? Yeah.
The relatives that may also be in trouble.
Right.
What happened to the neighbor's house that didn't quite burn, but there's still an issue there.
But they don't have electricity.
Right. Correct. Right. They don't have water. They don't have electricity.
Like in hurricane land, I have a lot of connections to this analogy.
Right. There's the window. There are no windows.
Right.
They can't stay in the house.
Right.
So I think over time, with the improvement of therapies, and I can certainly say as a provider, I certainly have more time to reflect on and to take a look at, just speaking of me independently, my patients that have moderate, mild hemophilia and other bleeding disorders, because I spent a lot of time managing people and families of people living with hemophilia, especially with inhibitors. I mean, not only did I have a lot of severe patients that were struggling, and we were struggling to help to manage, like constant, right? Trying to manage that. Patients who were living with inhibitors, it was daily, many times during the day. There was a lot of intensity there. So once therapy's improved, then you really, again, kind of have the time to look around. And collectively, we had the time to look around. And collectively, we had the time to ask additional questions. And to not only look at men living with factor levels that are in that moderate to mild range, you now also cannot ignore the women who fall into that same category.
Right. And for every severe male, I mean, I know what the statistics are. I think MASAC just put out a note about this too, that there should be like 50% of, could potentially have the females in the same bloodline could be affected. But I mean, between mom, daughter, granddaughter, cousin, I mean, you could easily have 3 females for every severe male.
Oh, absolutely.
That are surrounding that person that just don't even know.
Absolutely.
And dealing with, maybe it's not just extended menstruation cycles, but maybe it's also like having trouble in childbearing. Maybe it's having difficulty with joint, microbleeds, all kinds of things.
Listen.
We've seen so many women that had like joint damage at age 35,
right.
And you go, oh, you probably just have some arthritis.
But
Again,
why would you have arthritis?
Yes, exactly.
At 35 years old, and you're an otherwise healthy female who doesn't have autoimmune disease. Like, well, why would you have that?
Right.
So there's so many things, and thank goodness, right? The therapy's evolved and allowed us to have an opportunity now to ask these questions. But it's linked to other things, right? So you brought up childbearing, right? And childbirth. So all by itself, that's associated with significant morbidity and mortality, right, for women.
Right.
And so
still, it's shocking.
It still is.
I look at the numbers of that sometimes, like on the World Health Organization puts out and all that stuff. It is unbelievable how many people still are impacted by that.
And it's actually for women of color and women of kind of marginalized groups from a socioeconomic status, apparently it's gotten much worse, actually, believe it or not. Yeah.
Oh my gosh.
But when you have something like that already exists, is the point.
Right.
Then women with bleeding disorders would kind of get lumped in and hidden within that group for the larger medical community where you like, that's a problem. Yeah. But within that problem are hiding women who have that problem because they have a bleeding disorder. Right. But it has become almost like an accepted norm, an accepted fact. Yes, that exists. In medicine, they would say anemia is the 5th vital sign. The vital sign that we really don't pay attention to. The vital sign that we should pay attention to because it can have such a significant impact systemically. So when you're anemic, your heart works overtime. Wow. So that puts you at risk from a cardiovascular standpoint. If you have decreased oxygen carrying capacity, well, what is that going to do to your brain? Right? What is that going to do for you from a memory perspective? Are you going to be able to function optimally if you're walking around chronically anemic? But again, that's one of those things that in medicine for us has been accepted for so many women because, women have heavy periods. And women can be anemic. And just take iron. Just take this birth control pill with iron. Right. It has been an accepted.
We just have to give some extra women have to have hysterectomies because they just bleed.
Right.
And
we just do
that's just what we have to do.
It's just a part of what we do.
Right.
So again, it was kind of lumped into things that were accepted. Right. So even now with the advancements, it's hard to kind of tease that out of what has become like an accepted norm. In addition to, you know this about me, but all the folks listening probably maybe not know about me, know this about me. I'll just speak my version of the truth, even if it doesn't sound right.
Girl, you gotta say it.
I'll just speak my version of the truth.
That's what I love about it.
Yeah, coagulation is not one of those things in medical school that most people like.
Yeah. Well, probably because of all those people telling you nobody's going to like it first.
I'm sure that has something to do with it.
We gotta go train these people that are like managing the fellowship.
Yeah.
I think that's where we start.
Most people don't like it. Like you're not
gonna like this.
And you spend
You're
only the
definitely
time
not.
that you have to spend. You learn it and you move on.
Yeah,
right.
yeah,
It's a blip on the radar for most doctors.
Yeah.
You know a little something about bleeding.
Yeah.
But you don't have that intensive training. Even most hematologists, oncologists, do they know about it? Sure.
Right.
Did they know enough about it to pass the board exam? Sure. Right. Could they treat a patient with it? Sure. Because they're qualified to do so. But they don't necessarily have like the experience or the interest.
Right.
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 Or the repetition. They're not a part of that community.
Context.
That, right.
Right. Yeah.
So it's a little different.
Abilities,
So again, coagulation for most doctors is not something they like. It's not something they want to do. And again, even my hemonc colleagues, they would prefer that you do it. Mm-hmm. You're doing that coag thing. Great. Can you see these patients for me? Can you handle that for me? So because it's something that has kind of been pushed out and marginalized,
even within the
medical
medicine,
community,
right.
It becomes a little bit of a problem now when you have to interface with physicians for care.
Do they treat? And I'm just asking because I don't know. But do you feel sometimes like other physicians treat you as like a second-class citizen, almost as a physician, where they're just going, "Well, that's your thing. We'll just kind of give it to you, and we're going to move on." Do you feel that?
It kind of runs the spectrum. So there are some physicians, especially like some surgeons, like when they're doing procedures, who are like, "Oh, you're the coag doc? You the hemophilia doc? What do I need to do? And where are you going to be? And are you going to help me do this? Are you going to tell me what I need to do? Are you going to take care of such and like they ask a lot of questions and they want the participation. They don't want anything to go wrong. They're open to whatever you need to do. At Tulane, we would stand in the OR. Most of the time it was the nurses. If I was available occasionally, it would be me. Right. But then the other side of the spectrum is I don't need you to tell me anything. I know what I'm doing. I've operated on patients who have this before. I've seen this before. You don't need to tell me how to do this. So there's a spectrum.
Yeah.
Right?
Right.
And then there are the people who fall in the middle. And so there's so many variables and factors, right, that we're facing when we're talking about people who are living with mild to moderate hemophilia who still bleed significantly. There's a risk of life or limb depending on the situation. And those people include women. They also include, which we're not even going to touch necessarily today, people who are living with other rare bleeding disorders. They're a part of this, right? So there's so many factors and variables that contribute. So you threw out a question earlier about factor levels and do they change and can they fluctuate with women? And the answer is yes, because in people who actually produce factor 8 or factor 9, that can change with stress or time or age because it's what we call an acute phase reactant. So depending on when you're testing it, depending on where that person falls, it may be higher one time, lower another time. So there is some variability. Some of them change with age. But will it ever be completely quote unquote normal? No, I don't believe that part. And then there's that whole question of, and this is tough. And even for someone I think who's very seasoned in terms of my experience with bleeding disorder patients, when I have a patient and a factor level is drawn and is documented as normal, I absolutely understand why there would be a challenge for some people. So even right now, there's several women I'm thinking about who I know they carry the gene. The factor levels are normal. What do I do with that? I don't need to treat them to prevent anything. If they're not symptomatic. I don't need to address it. There may be conditions and times, depending on what it is, that I do have to address it. We would probably have to have an ongoing plan, like depending on what it is. But I empathize and sympathize with the provider who doesn't have the experience to kind of ask those questions and may just check off the box and say, this woman's factor levels are normal. I don't need to do anything. I, on the other hand, may have a conversation where I'm looking at, let's say if there's a surgeon involved, and I'm like, listen, she doesn't have a very strong history of bleeding, but there has been some, especially from a menstrual standpoint. And her factor levels fall within the normal range. But I don't necessarily want that to be a false sense of security. So we have to have, I think, a crisis management plan.
That's good, yeah.
But we would have to be sort of in agreement, like with this, and explaining if you have unexpected bleeding, in addition to what you would normally do, here's plan A, plan B, and plan C.
And for the patients that are involved, I think about so many guys that they've, again, their mom or maybe it's their daughter now, may not really see it the same because again, you're putting that fire out of the house, trying to all the time. But
don't see
but
it
for
that
the men,
way.
but I think it's important that we give the people the language to even ask the questions, because how does that conversation even come up? I mean, I think a lot of treatment centers now are starting to look at, hey, let's just go ahead and do blood work for the family so we understand where some of them, but not all are. And a lot of that's driven obviously by payers and insurance and all that kind of stuff. But I mean, I do think like at some point, if the daughter is coming and saying, hey, maybe they don't understand why, but they're saying, hey, these are the things that I'm honestly having trouble with, or I had a tooth extracted and it just bled and bled and bled and bled. Not just, I think within our own family context, sometimes we can just push those things aside and say, oh yeah, it's probably like a little, but if we bring that to you and we say, hey, how do you feel about it? Then that I mean, it is really, that's the impetus that starts the conversation so that you can create a crisis plan, because you can follow that person, that child, maybe that mom, maybe whoever for many, they're probably gonna have lots of medical things that happen throughout their life, and having that plan develop. And so I think it's imperative that we as a patient population and community also formalize this understanding, like this could be a thing. And we probably should at least just know, like I remember recently my wife went to go get some blood work done or whatever, and it was a EKG they were doing on her heart, and they said we just need a baseline to where you're normal, like just where you're regular and not in a crisis, so that later on in life we just can come back and go, okay,
this is what it looks
this
like.
is what it was, and now 5 years later, this is what we know it to be now.
That's right.
And so I think. But that all starts with, at some level, like if my wife didn't go to the doctor at all to just get a normal checkup, that conversation probably would never have happened, and there would be no baseline to measure it against, right? So I think at some level, like we need, as a patient community, we also need to be asking the right questions, because it's important that we do get a crisis plan, because if you're in a car accident or something else, that could be
it's important.
You can't diagnose. I mean, you shouldn't be trying to diagnose in the middle of a total disaster trauma like that, right?
So I think, we could probably take that back a little bit and, let's say, what are the tangible things, right, that can be helpful that we can kind of concentrate on? And, let's start with, if we're talking to people kind of within the bleeding disorders community, right? Someone you love, know, related to, right, has a bleeding disorder. I'm a mom. I have 2 sons, with hemophilia. You have to understand that even if no one has ever asked you, that it is possible that you are at risk from a bleeding standpoint. You have to first understand that it is absolutely possible. So because it's possible, there are 2 additional steps that you need to take. Starting off with, yes, it's possible. recognizing that you probably should be tested to determine where you fall. But then it can't end there. You have to recognize that maybe in spite of, or no matter what happened with that test, even if you don't have genetic testing, do you bleed? And what does it mean to bleed? So there are so many women and just people in general who don't understand, like, I don't know what that means.
Right.
What do you mean bleed? So do you mean when I get up and brush my teeth every day and, I'm spitting out blood the whole time I'm brushing my teeth, that's not okay? Right? If I have a nosebleed every morning before I go to work,
or in the middle of work.
Or in the middle of work, right? You mean like, well, that's not really okay. Or, when I was 12 years old and I started having periods, I couldn't go to school for a week because I had to wear pads, tampons, and a diaper. Or, there's so many. So first, I think we have to recognize that, yes, it's possible that you could have a significant bleeding disorder. And then two, it's important that you understand, well, what is bleeding for me as a female? So not only do providers have to be educated about that, but the community, patients, women, we have to understand, what does it mean to bleed? The third thing would probably be, sadly, that there are not always going to be my colleagues or other providers who will understand how to help you.
Sure.
It's not that they don't want to help. It's not that they are, doing something deliberate. I think it's just so many people don't know. They don't know how. So first, understanding that it's possible that you could have a bleeding disorder. Second, understanding it's important for you to learn or know or understand what is bleeding for me.
For me, right.
If I have frequent ankle sprains.
Yeah, right.
Am I really having a joint that's being injured and now I'm at risk and I need to pursue that and push that?
Right.
And then finding someone who can help you. And I'm going to quote my husband real quick and say, we were talking about doctors and sometimes the limitations that you face as a patient if there's something your doctor doesn't know. Some of them are smart. Some of us are smart enough to say, well, I don't know that, but I'm going to explore it. And sometimes not. And my husband said, well, so I'm just at the mercy of that because I don't know. And that's right. So this is where I think organizations like yours and when communities come together, that you can talk about what some of the barriers are, what some of the challenges are, and maybe how you could overcome some of them. You could address the education.
It's a language, right? To think about it, to chew on it, to say what are the commonalities we're experiencing. I've been amazed the more that I've learned about just modern medicine and in general. I've really been amazed at how much anecdotal things are experienced, things that we go through that are what really push medicine along. I think in this modern age, we think, well, everything's known and, everything's got a lab and everything's got a test result. And, we just go to some specialist and they tell us what to do and then we just follow those instructions. But truly, there's so much that's still not known. I mean, I think about what, and a lot of it's just because we're continuing to grow and understand. It's the forest from the trees thing. Sometimes we're putting the fire out in the house and then we get to assess, okay, wait a minute, this person has a burn that could lead to an infection that could lead to really, really traumatic, amputation because they didn't get it treated properly or within time. So it could be eventually severe, be down the road. And I feel like that even within the bleeding disorder space, I've been talking about this a lot. You just brought it to mind while you're talking about defining what a bleed is for you. You probably heard me talk about this, but I talk a lot about we have leaned so much on this concept of ABR or annual bleed rate. But if I ask 10 severe guys that are like, they've lived with fully metastasized bleeds that are just extreme. If I ask 10 guys what a bleed is, I'm going to get 10 different answers.
Yeah.
Still in this day. Now, some of that is because the advancement of medicine has grown so much and there's so much good treatment out there that's really doing a great job at managing all that preventatively. But at the same time, I hear guys, I mean, literally, it's surprising to me sometimes we'll be in a room and there's 30 people in there. They're all affected, and you go, okay, describe to me what a bleed is. And it'll be crickets for a little while because everybody's on treatment of some kind, which is wonderful. That's progress. It's amazing progress compared to what it was when I was 8, 9, 10, 11, well, even 20. It's
Right.
years old. You know, there's a different day where that was not the case. And we all could tell you, well, I can tell you, I can't walk. I can't, you know, whatever. But at the same time, like knowing what that is for you is so critical, even now, even for the extreme end of the spectrum. But how much more so is that the problem in moderate or mild hemophilia, where men, women, whatever, it still could be a problem in a lot of different ways. I've said for a long time that I think in mild hemophilia is probably like the Wild West right now. It's the most dangerous place to be because you could be in a car accident. We just had an amazing meeting with a lot of legislators recently in Washington, D.C., where we were meeting with, but one of our friends that was a patient had been infected. Her dad passed away from a completely solvable problem because he had moderate hemophilia.
It happens all the time.
He didn't have factor with
it.
It
happens all the time.
Instead of a wristband, he actually had a thing in his wallet, and he was in a car accident, taken to the emergency room. They called the family, and by the time they went through his wallet, he had passed away from a brain bleed.
Yeah.
That kind of thing is still going on every day. And most often, cause of death was not listed as hemophilia.
No.
Cause of death was head
brain
trauma.
bleed.
So even in the records, it's
it
not
doesn't
being
say.
truly
Acknowledged.
unpacked. And
Yeah.
so does that ever get down to the school level where we're training physicians for the next generation? Probably not.
Yeah.
And if we as patients don't have, if we're not able to raise a flag, I always say, you know, there's a fine line between advocating and being adversarial. And sometimes I think a lot of people, when they don't feel like they're getting answers, they go to the physician appointment or the clinic visit, and they just go in with their dukes up and they're like defensive and all this stuff. And I just, as I've gotten to know you more and so many other physician friends that we all know and love, it's like, I've just grown to realize, man, you guys are human just as much as I'm human. And I can't go into this being like, I have an opinion and you're trying to be a gatekeeper. I got to go into this like, we're a team, and how do we work together? And let me bring up everything that I'm thoughtful of, and then you can just help me pick and choose which one is better or worse. We had a situation with a female that had a really borderline factor level, borderline, and it was not a black and white thing, and found out through ultrasound that there was joint damage as a teenager. And through that process, got diagnosed on preventive treatment. Total life change. I mean, total life change. Gave her life back, and she didn't even know she was struggling because she had soreness and she had every day. She had all these things. Didn't realize all this stuff was going on, you know. And even for my own, I mean, here I am preaching on the stage and whatever, doing my rah. And, you know, I had my clinic visit with my physician recently at the beginning of this year. And we sat down and looked at it and went through the things and said, we can do better. Let's go to this. Let's correct to 100%. Let's don't just correct to 60, 70%. I thought I was a totally new person.
Yeah.
And look, I kind of know a few questions to ask. I'm not the most expert, but I kind of know a little bit about what I'm talking about. And so you would think I would have thought to ask that question, but I didn't think to ask that question. I didn't think to push the envelope because that wasn't again, it goes, I love the house burning down analogy because it wasn't the biggest problem in my life. But by going through, hey, here's the list of challenges that I'm experiencing. And then collaborating with that as a team has been, I know it's been life-changing for me. I know it's been life-changing for many other patients. And sometimes providers aren't always the most empathetic, but at the same time, I've found, at least in hematology, seems to be, there's probably more that have a lot more empathy than there are maybe in, I had an orthopedic surgeon one time that was like military, like no expression. And, you know, it was like, I walked out of there thinking, that guy, I'm not going to see that guy ever again.
Yeah.
But he saved my life.
Yeah.
And I didn't know that I needed him.
Yeah.
So sometimes they're the most, you know, but in hematology, it seems like a lot of our treatment centers, at least, and a lot of hematologists in this space are really, you know, more empathetic. But I think we got to give grace to each other, and we got to give grace to the whole learning process for all of us, because at some level we're learning. But I think it starts with language. And then it starts with just investigating and realize that really, if we're experiencing this, the onus is on us. It's really on us to really start to explore and discover and process with, and especially if you have someone in your family. You know, I think this phrase is one that keeps coming back to mind, and I feel like has been very effective in a lot of circles, and that is, bleeding disorders runs in my family. I think we should investigate this. And just by saying that, all of a sudden it seems to unlock a switch, whether it's a PCP or if it's your whatever that is, OB, GYN, like whatever that is. I have a history of this in my family. I think I need to look into this. Yeah. And that has been a great way to sort of unlock conversations and see an investigation.
Yeah, it's just so complex, right? Because at the end of the day too, it's about feeling confident in a space. Yeah. And it's also about having a relationship with someone. And so a lot of those things are much easier for us who have a relationship with the provider. Like you've established some sort of relationship, right, with that provider. Right. You're also coming from a space where you're confident enough and capable enough to kind of communicate, you know, with that provider. And if you're also fortunate enough to have a provider who is inquisitive enough or knowledgeable enough or confident enough to...
Or a science nerd enough.
That part. Or a science nerd enough. Yeah. Yeah. To really push the envelope and ask the additional questions.
Yeah. That's good.
That can be tough to kind of, you know, put together. Yeah. And it's also another piece to this too. Like if you're not getting the answers, you're not getting to the solutions, don't stop.
That's good.
Don't stop. Go back to that provider again.
Right.
You know, give them the opportunity. Hey, listen, I'm really concerned about this. And is the workup that we've done here like really enough? Can you help me to really explore and find out, like, is it really enough? Because something's not right. And can I follow up, you know, in a shorter time frame, because something isn't right? Now that's easy to say, the way I said it, when I don't have a crisis going on. And so even recently for me, my daughter was in a car accident. And inside, I was almost screaming at these people that, no, under these circumstances, you need to do a CT. I was almost screaming. But I was with it enough to control myself and not let the inside screaming come to the outside, because then people match energy and it becomes about like my behavior and we can't have a conversation. So I tried to, as calmly as possible, and swallowed real hard, right? And said, so there was a significant car accident. The car is decimated. Here's a picture of the car. She can't tell me, all the airbags deployed. She can't really even tell me exactly what happened. Under what conditions would you want to look at someone's brain when there's been that kind of trauma? And if something happened and it wasn't witnessed, you know, or if the person who was engaged in the accident, again, can't really tell you anything, under what conditions would you investigate? So do you think that this would call for like a CT to be done? I had to try to very calmly, you know, pull that together. And ultimately the answer was yes. But had the answer been no, my response would have been, I don't really feel comfortable with that. can we discuss this a little further? And is there anything that you can do to kind of, to really explore that?
Yeah.
I don't feel comfortable with that.
Mm-hmm. I want to peel that back a little further too, because I think there's a deeper thing here that it's crazy unfortunate, and it's a complete reality that insurance, unfortunately.
I had a bad week with insurance.
Sorry,
I had a bad week with insurance.
I don't mean to create PTSD or anything. But
my trauma triggers.
I'm sorry. I don't mean to trigger.
Yeah.
But we gotta also understand that sometimes the barriers to doing more investigation in moments like that, whether it's trauma or whether it's, whatever, labs, whatever, that there's a barrier in the sense that, and again, I'm asking because I haven't sat in your shoes or in your seat, so I don't know. But I'm just curious, like, when somebody asks you a question, are you going through the checklist in the back of your mind, like, basically to answer the question, is insurance going to even allow me to do these tests, like this because at some level, it's not just about what the patient wants. Like, at some level, it's like we could want all the things in the world. We could even be right about, and our suspicions could be absolutely accurate. But if you can't get it funded, if you can't get it paid for, then none of us really have a,
I call it the silent provider in the room.
Yeah.
Right. And so, there's a silent provider.
Yeah.
Right in the room. And for the most part, most of us are pretty well versed with what our limitations are in terms of like insurance. Like, what can we do? What can we not do?
Right.
I know what I can do in an emergency. I know what I need to describe adequately. Right. If a patient has something, over the years, I know how to make sure that I'm explaining, myself so that they have enough information, right, that they need to authorize, right, the test. Sometimes, even with me going through all of those steps, it's still not authorized, and then it requires me to have what's called a peer-to-peer, and now I'm having a conversation. Those things are barriers, right? Yeah. Some doctors don't get to do them. Sometimes they're very hard to set up. The barriers are just there.
So is that part of the checklist you're going through when somebody brings to you, like, hey, I think I need a chromogenic testing, not just
it can be.
And I'm a female and I don't have like a confident history, but I really believe.
Yeah, no, it can be. Yeah. But it becomes, for me, it becomes a part of the conversation. Right. So if I'm like, listen, I absolutely know that you have a rare bleeding disorder.
Right.
It walks like a duck. It quacks like a duck. It's a duck. I'm very confident that this is here. This is what I'm dealing with. With the lab tests that are available to me, this is very difficult for me to diagnose this. Right. I'm probably not going to catch this. So this is how we have to operate until we can do better. Now, what would be better is if I had genetic testing to confirm this, but your insurance is not going to cover this genetic testing. Right. So then what do we do? Right. I have a choice. Either you're going to pay for it at $1,000 a pop, $2,000 a pop, or I'm going to say we can't afford to get that. I'm going to explain why. But it's going to be a conversation and shared decision making between me and the patient. Right. Now that's me. Again, that's with my level of experience and the kind of provider I am. You may not have the same conversation, with another provider. Right.
But I found sometimes, like, from the patient seat, sometimes, like, just going and saying, like, that surface level answer, if you feel like that's what you did with your daughter's accident, just asking more questions is a great way to sort of maybe to take them out of the instant no or the instant it's probably not going to get. And you're
not challenging them. You're not putting the person on the defense.
I love what you said is that, like, when you give a certain energy, they're going to match that.
They're going to match that. People match energy.
True.
I match energy.
Oh my gosh. Yeah.
Yeah. People match energy. Yeah.
But by asking questions and staying inquisitive and saying, but if this were the case, if this was your daughter, like, what would you, and you saw these symptoms, would there be anything else that we should be considering? That I mean, I've gotten to the point now where I like asking this. This has worked well for me recently. Is just not maybe in this exact setting, but in a lot of settings, you're going, okay, is there any other questions I didn't bring up that I should be asking? Because sometimes I found, some of these people are way smarter than I am. Yeah. And it's like, when I ask that question, it gets their, their lab brain going, and they go, well, I wish you'd asked me this question, or whatever. They start thinking it, and they start feeding you the very questions you can ask. So getting them to the point of like, let's collaborate can be a little bit of a skill sometimes, but it's so critical, right?
It is critical. But again, it's one of those barriers when you're not the person, right, who knows how to do that, right? I'll give you another kind of personal example. My mom is older. She fell. She broke her wrist. It was not witnessed. Right? Okay. She has dementia. She fell. It was not witnessed.
Okay.
We don't know what was associated with the fall. We don't know if she was having a heart or cardiac event that made her fall. We don't know if she tripped. It wasn't witnessed.
Right.
Right? All we're just looking at an elderly woman who has 2 broken wrists as a result of a fall. So she's at the hospital with my brother. My brother's an educated guy. The doctors did whatever they did, and they came and said, well, your mom has 2 broken wrists. We're going to do such and such and such and such. And, blah, 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 blah. And here are your instructions. And what does my brother say? He goes, okay. And what are we supposed to do? And okay. And blah, blah, blah. And okay. And you're going to discharge us? And okay. 2 seconds later, I roll up, right? I'm coming in hot from New Orleans. I roll up and I go, what's happening? Well, they're about to discharge Mom. Okay. And what did they do? Well, they did some x-rays and they said she has 2 broken wrists. And I said, and that's all they did was some x-rays? And they said, yeah. And I said, okay. So the nurse comes and I said, I didn't introduce myself as a doctor. I tried to, again, I'm not calm inside, but I tried to remain calm. And I said, well, sir, you're her nurse? He said, yes. And she's being discharged? I said, well, I do have some questions for the physician who's caring for her. So if you could let him know, we'll wait when he has time. But I don't think that she should be discharged right now, and I have some additional questions. So can you just please point out to him, just in case it wasn't pointed out when he's on his way over, or her way over, that this is a 80-year-old female with end-stage dementia who had a fall that was not witnessed. And we'll wait. And so when he went back and maybe they didn't necessarily have, right, all of those facts. Like maybe, it's busy in the ER. It's just an 80-year-old who fell and they didn't really get to the bottom of blah, 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 like whatever it was.
Right.
But when I said, no, I'm sorry, we do have some additional questions and here's some additional facts. All of a sudden she had an EKG, a chest x-ray, a head CT, because those were the appropriate things. Right, to do. But there's nothing wrong with my brother. He just didn't know to ask those questions. He just didn't know to ask those types of questions. And so that's where I think we're getting to the sort of meat of this for women and girls with bleeding disorders. It's not one answer. Are you expected to always have all the answers for yourself? Absolutely not. But it does help if we could try to empower the community with even what you are capable of doing. So even if it's only to start by saying, I have a family history of a bleeding disorder, and so that means that I might have one too. And I don't really know what it means to bleed. Let's just even if we're starting there, right? The other complexities of knowing how to talk to a provider or knowing what provider to go to, well, maybe that's when, again, amazing organizations like yours in feeding back into the community and providing support and providing education, you can help to uplift people, who face all of those barriers, because there's so many barriers, right?
Yeah, so true.
I think it's we're in a wonderful position.
Language thing. It's just giving us a unified language to be able to say, like, okay, let's think out. Just knowing what questions to ask can be everything. It's not about being combative or trying to say that you know everything as a patient, but it is about just continuing the conversation through, the old adage, you can track more bees with honey than by vinegar.
But sometimes you are met with some combative energy.
That's true.
Like you are.
Right.
And that's not always fair.
Right.
And it's not always right.
Yeah.
But you can't stop when that happens,
That's
right?
true.
Like when you feel very strongly and you're concerned that something is going on,
Yeah.
if you need to leave one emergency room and go to another one.
Yeah, get a second opinion, get a third opinion, get a fourth opinion if you need to.
You absolutely need to. Or even if it's, I don't really feel comfortable with this. I don't mean to challenge you. I really don't. But can we talk about this collectively? Is there anyone else here that we can have a conversation?
Yeah, just bring in de-escalating. This
Right. Is it?
Yeah.
But again, I may have the skills to do that. Deep down inside, I'm like, no, go get your supervisor. No, I'm like, no, you go get but I'm not.
You better get all New Orleans on them.
Yeah. You go get your supervisor, baby. No, yeah, I'm suppressing that person, but that's not easy for you know what I mean, for everyone, everyone to do. And Lord have mercy, don't add in the other preconceived notions about sometimes what people look like. Or how they're dressed, or how they talk, or anything else. When you start adding in all those other factors, there can be issues. There are many things to fight. I think we have to take them sort of one at a time.
That's good.
We need new diagnosis codes.
Yes.
We need new ways to identify bleeding in women.
Yes.
We need more providers who understand how to manage women and girls.
Yes.
We need more evidence-based things to go to. So we need more
women in
research.
trials.
Yes, we need more women in trials. We need more research. We need things like Athen. I'm now the chief science officer for Athen.
Yeah.
We need people in the community to understand. You like Athen? Who? What is Athen? You need to understand what
Greece?
Athen. Yeah, what is that? The American Thrombosis and Hemostasis Network. You need to understand by participating in that how you're contributing, to the community, and then ask questions. What's happening with this data?
Right.
Like, is there anything that's really going towards women? Ask your doctor. Are you participating in research for women?
Yes.
Like, what can we do? So there's so many boxes that we need to check off. And we have to start somewhere.
That's so good.
Right? We have to start somewhere.
I know that there's been, you bring up Athen, and I just recently, was able to sit in on the MASAC meeting, which was so.
I'm so glad you had that
and I
chance.
have to say thank you to you for really pushing. You've told me about coming numerous times, and I've just always been like, well, I got this or that or this or that.
It's information is power.
Oh my gosh, I was just mind blown, and for all the advancement that we do in all of society, right? I know there has been a lot of fingers sometimes pointed at MASAC at times, and I, I've been one of them. At times, I've kind of been frustrated with the lack of progress. But after participating and seeing and being involved in that, I for a minute I just realized, like, oh my gosh,
the time,
there's a methodical,
the thought,
genuine,
that's
intricate
the effort
process
that's going through that.
And in order to be thorough, there is a longer timeline.
Yes,
and then you just gotta put it out there and then see how it interacts with the other providers in the treatment and all the other things going on. And so then you got to wait for that response. It may be 3, 4, 5 years before that gets revisited in another thorough fashion. So, anyway, I just wanted to say, thank you for inviting me to that, but also thank you for investing in it, because you've been a part of that for a long time. But I guess as one of the things that was really exciting, because at that meeting in particular was voted on this new document 286, which is specific recommendations for the management of inherited bleeding disorders for girls and women with personal and family history of bleeding, which
that's right.
It's a really lot of words there, but there's really no other way to shorten that, because it really is important.
You have to be inclusive, right? You want to make sure you hit all the buttons.
But that document, I if I understand it correctly, I don't think it goes as far as to saying these are the new protocols, but I do think it's a recommendation to say, hey, we've evaluated this with a great deal of thorough measure, and this is kind of the conclusion that we came up with, the best minds in the business, if you will, and this is what we kind of came to as a conclusion. And it was interesting. For the first time, I felt like I really heard what we've all been kind of discovering in the patient community, as well as what some treatment centers and providers have also embraced through the years. There seemed to be this resonance within this document that that said, I actually had recently a conversation with the CDC on this about the discrepancy between NIH saying that it's anybody 40% or lower.
40 and 50%.
Yeah, and then the 50% from CDC. And I'm hopeful that in the next few years we're in conversations, hearing a lot of things, but I'm hopeful that NIH will go, that number will kind of get washed out of the system, because I think there's a lot of reinforcement behind this 50% number. But at the end of the day, arguably, I heard a physician say this one time, one of our mutual friends, it's a hematologist in another area, said, arguably, if you have anything less than 100%, first of all, the range is not 0 to 100. The range is 0 to really 270 or something like that. So it's this idea that there's a pretty broad range that has been observed in society. And so the question is but if you're less than 100%, there may be moments in your life where you could benefit from some supplement. Now, that doesn't mean if you have 99% or 90%, whatever. But the bottom line is anything lower than 100% could be considered.
Let me throw something in there that kind of justifies that too.
Okay.
Right. So let's say for me, I don't have or carry a gene for hemophilia.
In your heart, you do.
In my heart, I carry all of it in my heart. Yeah, not in my genes, but in my heart. Yeah, yeah. So because I don't have that, if my factor level right now, if you test it, and it's 87%, but when my body is stressed, and I need to have more factor 8 or factor 9 available, my factor level might be 187%. But a woman who carries the gene for hemophilia may not have the ability to do that or generate that.
Interesting.
So there's a dynamic here, right? There's something that could be different about that. So these are some of the things when the Medical and Scientific Advisory Council for the National Bleeding Disorders Foundation, I almost said NHF, yeah. For NBDF, formerly known as.
It's like Prince,
formerly known as. Yeah. So when we are making recommendations, we're making recommendations with our experience, but with a foundation in what's based in the evidence, like what we have available to us. We're talking about the physiology, right, of a condition, what happens with your body, like the changes and what may or may not happen if you have a bleeding disorder or family history of a bleeding disorder. So we understand it's not necessarily just about the factor level that you're looking at. It's about everything that surrounds that, right? So there's a lot that goes into that.
Yeah, there's a lot still not known, like how do hormones interact with that? How does enzymes interact with that? There's a plethora of other things that we still are like iron deficiency, all of these things,
there's
minerals.
There's so many things.
Yeah.
But what I think, in you pointing out the MASAC guidelines, right, and these recommendations, is so important, even that it's there for women.
It's a baseline.
It's a baseline.
Right.
It's there. And the thing about guidelines and recommendations, so that really provides a place that if you really don't know or don't understand, in addition to the literature, this is a place where you can start to sort of try to understand, well, what are the people in the general community kind of recommending and what's done? The references are there. You can go back and use those references. So
even for insurance approvals.
Now the danger,
to sort of substantiate, right?
We
the
can
argument.
use it. We can use it for insurance approval, and so there's some power in that we really have to take seriously. Right. So,
and what I love about this particular document, which I have to say, I felt like.
Well, you got to see how the sausage was made.
Yeah, and it was beautiful, and also the parts of it that also were, I think that I just got more context of why there's frustration sometimes, because it's like it's just a long process. This is how the sausage is made. It doesn't happen overnight, and but for the sake of it being thorough and accurate and intentional, there's a need for this. But one of the things I really did appreciate that I felt like I heard the voice of the community in unlike maybe some of what the past thoughts have been on this, is this last sentence here says, I'm just going to read it because there's no other way to say it. It was just, additionally, while low factor levels are generally associated with a higher risk of bleeding problems, abnormal bleeding symptoms may occur with normal factor levels in up to 70% of genetic carriers of hemophilia. So one of the challenges I think we've heard a lot of is that like there's this, you talked about diagnosis codes. I think still most women, the code itself is going to say symptomatic carrier, even though we say, okay, the predominant line of thinking now is if you have a 30% level, you have hemophilia. Like it's not really, but the diagnosis code, if I'm not mistaken, correct me if I'm wrong here, but I think it still is going to read on that MIB report as symptomatic carrier because it's a female, so we need another code for that. We need another diagnosis code. But the bottom line is that the fact that there has been observed, and that in this document to say if there's as a baseline, as a way to sort of a starting point, this document 286 really said something that I thought was really interesting. It says it spoke to the fact that it's not just about above or below 50%. It's not a hard line. It's, you got to look at the symptoms. And by the way, this could occur in normal levels. I interpret that to mean, which again, novice at this, but I feel like that what I'm hearing in that is that normal factor levels it would be above 50%. So if you have a 60% or a 70%, that there's some percentage of time that they will have potential bleeding symptoms, even if they're over 50%.
Absolutely. And that goes back to the explanation that I kind of gave you earlier, right? So in a carrier, a woman who carries the gene, that causes, factor 8 deficiency or factor 9 deficiency, that woman, even if that factor level is measured at 65%, may not be able to mount the appropriate physiological response. So again, it goes beyond just checking off the box, right, for the factor level.
Right.
That is what MASAC is saying. Right. MASAC is saying, yes, that this is something that can occur. We know that it occurs. We're aware of the fact that it occurs. And just because you have a normal factor level does not necessarily mean that woman is protected. And that also goes back to the example that I gave earlier. What do I do when I have a woman who I know carries the gene that causes hemophilia A or hemophilia B, and the factor levels are normal, and there's a big surgery that's planned?
That's so good and so necessary. It goes back to beyond crisis management. It's also about, it's one thing that I wanted to mention here, though, that I think is worth touching on briefly is, we seem to be, and again, I have my pulse on like what's happening within the patient population across the country, right? But what we seem to be seeing is more and more women getting the diagnosis, but not getting treatment. I guess what I wanted to ask you is, do you feel like in the future, and I mean, I know there's tensions right now, and a lot of it, I believe, has to do with, and I want you to speak this because I may be seeing it wrong, but I feel like what I'm observing is there's tensions on two places. One is many of the treatment centers are at capacity, and they just logistically can't bring in another 100 patients. That's one aspect of it. The other aspect of it is insurance is pushing back a lot. And there's so many problems right now within the insurance space in the US in general, from AFPs to PBMs to, all the things. There's like a million problems going on in that space. So maybe those have more to do with this than it is just the science. I mean, I think we'd like to lean on and just say, okay, the science is here, and then MASAC says it, therefore it should be so, and whatever. But there's still a lot of other things we need to problems to be solved. But I guess the question is do you see a future for the community where more women may be on a once a month or maybe a twice a month preventative treatment where they're having extended periods, or they're having,
Well, yeah, I mean, I'm already doing that.
Well,
right? Like
I know, but you're a one-eyed unicorn under a rainbow, right?
So that's right. It's one of those things. Yeah. You know what I mean? Yeah.
But I mean, do you think that will become eventually the predominant line of thinking within treaters across the country?
I think eventually it will be. I think that, again, just real talk, right? Just being really honest, I think that it probably should almost be the expectation that even if you jump over all the other hurdles as a woman, you understand that you could have a bleeding disorder. You understand what the bleeding is. You understand like that you need to be treated. But then connecting with a provider who has both the experience and the understanding of what happens like with women, that is where the challenge may be. Mm-hmm. That's the real truth right now. That may be the challenge.
Yeah. I mean, case in point for me, I have 4 kids. 2 of them are girls. They went through a period of time where both of them did not really have extended menstrual cycles. Other symptoms, they were playing sports, had problems. And retrospectively, we look back at those years and go, oh my gosh, like in some ways it's devastating because you realize it was right in front of my face the whole time.
Right.
I wish I would have spoken up. I wish I would have said something.
But remember, you have to remember, though, we were all in the same boat.
I know.
Right? The house was on fire.
We got to give ourselves grace.
Yep, they got to give us grace. The house was on fire.
Right. Yeah. But nonetheless, like that, you want to talk, why is this conversation so important for Jonathan? Like that, I mean, that's a driver for me, right? I don't want to see anybody else go through unnecessary suffering because of a lack of understanding. And so that's what drives me. But in that, I also simultaneously saw that there was a place where even when we did ask questions, the predominant line of thinking was like, well, do they have extended menstrual cycle? No. Well, then they're probably okay. I mean, like no investigation, no, and I'm not pointing fingers at anybody. Again, we, like you said, we were all in the same boat. But I do think that at least I hope that enough progress has been made and observations have been made that not only will that start to invest, let's just, I was just with a geneticist actually from Tulane, not hemophilia related. We were part of the Rare Disease Advisory Council for the state legislature here. And I was talking with Hans and he said, specifically,
I love him.
Oh, he's amazing.
Love him.
But he said specifically, which again, I'm just quoting him in this. I haven't read it myself, which I'm sure I trust everything he says. So I would trust this too, is that genetic testing is now on formulary for every insurance provider across the board, which is great news. So maybe there's a day coming that we can get to that where it's just like, you know what, you're in the family. We're just going to test everybody, see where everybody is. And if you have the chromogenic, or the dispensation towards this genetic mutation, then we know the markers are there. Therefore, the levels almost become, matter of fact, I think levels have been kind of a primary form of looking at it now. I do think phenotyping and understanding that there could be a positioning for that just because of the gene mutation actually could be the way that we're looking at that in the future. And maybe that's just it's just automatic, hopefully. I don't know.
We have this dream project with Athen. And I know there are a lot of treaters who are very interested in this too, that every female, born, with a family history of hemophilia, of course, when we know there's spontaneous mutation, so not discounting for that, but every female with a family history, that just as a male is tested at birth, that the female will also have a cord blood sample sent and a genetic sample sent.
Amazing.
Would that not? That's like our dream. That's like our dream project. Yeah. Our dream project is every female.
Right.
And we want to collect that data.
Right.
And follow those females kind of over time, follow factor levels.
Yeah.
Who wants people, bleed logs, but we need a bleed log to kind of track like what's happening. Right. What if we could even follow joints, right, of those women longitudinally to then have that information to say, well, this is what has happened over time. Now, those types of things take people who are willing to do it. It takes, financial support, but that's the kind of information that we really need to move the needle. Again, this is a war that has to be fought on multiple fronts. We have made tremendous progress, right, over time. we do have resources, Tulane, the HTC there, they've dedicated like an entire clinic. Like they're really trying to focus on, women and girls. I know that LSU like has an initiative, but they're really also like trying to, they've been involved with the foundation. So even here in the state, there are people who are trying, like they care. I already drank that Kool-Aid a long time ago. I now have my clinic at Oxnard. So at least, we have voices like within this state, but as we look at people like across the country, again, using your resources and the people and hope, right, as a tool to say, if I want to find a provider, and I'm in New Jersey, if I want to find a provider and I'm in Iowa, or I'm in Washington State, like where do I go to have someone who's at least willing to listen and have this conversation with me? Because it's not a one and done, with a woman or a girl. And so very early on, even when I have those conversations, I'm like, listen, I don't want you to think it's the one and done. We may need to follow this right out over time. I can't say that prophylaxis or anything has to start right now, but it doesn't mean that it doesn't need to be at some point, but we need to follow this out and understand what's happening. It's about having a provider, I think, who is knowledgeable and willing, to evaluate, but empowering yourself too with the information that you need to have. So
it's so good. I do a lot of work in advocacy in particular, just both with the Louisiana Rare Disease Advisory Council, but also with federally and in a lot of different projects there. One of the things that I'm really excited about the future is this idea that we could get a policy change within the Medicaid. Each state, we're working on one here in Louisiana, Accelerating Kids Access to Care Act, and the idea is that we could get specialists to where a child that has been identified as either having a rare disease or has a propensity, a genetic disposition for a rare disease, could actually be reimbursed for a specialist outside of the state limitations. It's a huge ask. It's something that's been pushed back on over and over again. But I actually feel like I see the beginnings of a glimmer of hope that there could be some of this legislative change from a policy point of view. And what we've told legislators is, and I think that this is a really big need, and it's not just for hemophilia. It's like a lot of rare diseases obviously have this issue. But when you have a specialist that's across state lines and you're on Medicaid, you cannot go to a specialist across state lines. Even many insurance policies won't allow you to do that. So, it starts within that Medicaid framework and then maybe Medicare. But then once you do, I think the downstream happens in commercial as well. But at the end of the day, that there's what we've told legislators is, and especially in the state of Louisiana, is if we can even show that they're having to go to Houston or they have to go to wherever to get a specialized treatment, it actually could help identify the number of patients that live in the state that have this need, and it could attract those same talented physicians from other states to come here.
That's right.
And so that's exciting about Louisiana, but we're fighting for that federally as well, in a way to see that maybe that from a CMS change that could actually free up the system to where people could go to the right provider across state lines. I know there's a million other issues that could run into there, but that's something we're advocating for.
That
and
is so important.
About the future.
It's so important. Yeah. It's so incredibly important. And I think that that's one of those issues that, when you start throwing out those DEI-like terms and you say diversity, equity, and inclusion, people automatically kind of go to race, right? And many times it has absolutely nothing to do with that.
So true.
So what you just mentioned, right, is like an equity issue.
Yes.
So if I have great health care, right, because of my job or my husband's job,
right,
and if there's no one here in the state that treats the condition that my husband has, well, we can hop on a plane and go to New York or Texas or California or wherever we need to go. Right. Someone who's on Medicaid should have a similar opportunity.
Right. That's right.
Right.
Absolutely.
Now, I'm not in any way suggesting
100%.
that it shouldn't, it should happen like with no restrictions, right? Or it should just be just kind of carte blanche. I think you have to establish that it's actually needed, first.
Right.
Actually, Medicaid in Louisiana will allow you to have a consultation. You can go across state lines to have a consultation. It takes an act of God. I've done it a few times. When I tell you it's like an act of God, like it is incredibly difficult to do. And it's incredibly difficult from a Medicaid standpoint to get that consultation approved. And it's incredibly difficult to get the receiving state to agree to it too. It is almost impossible. But that continued care, that's the part that can't happen. So when I have access to that and you don't, that's an equity issue. And so when we're talking about things like rare diseases, right? And women and girls, it's about having access to the same health care.
Yes.
So
especially if we say this has got the best health care in the world in the U.S. And unfortunately, because of these types of barriers, there's a vast diversity
That's right.
of people who are living right next door to something that could save their lives.
And they can't get to it
because they're just in whatever category.
Again, to like to toot that horn and say again, when you hear diversity, equity, and inclusion, those are the types of things, right, that we have to zero in on, because that's what really matters.
We deal with this a lot with rural health. We've been working with HRSA a lot on this because
rural health
with within the context of why are people who are 3 hours away from a hemophilia treatment center not participating in trials?
They can't get to it.
They can't get to it.
It's not.
So it's both equity and there's also this idea that there's missing pieces in a trial that need to be present in a trial.
That's right.
So that we
so
can.
You
have
don't
that
have
best
the
information.
You're not including all the people that you need to include. Right. You don't have the diversity of people.
That's exactly right.
Right. You don't have people who, again, there are different types of people.
Right.
So people who live rurally. Actually may have a different state of health.
That's right.
In general, in comparison to someone who lives in the city.
That's right.
Right. That's a certain kind of diversity.
That's right.
That we need to know about and kind of have as we're looking for different therapeutic options.
I agree.
When I was just 45 minutes outside of New Orleans, I was the only hematologist on that side of the lake that would see patients with Medicaid.
Wow. And you and I know that there's a ton of people on that side of the lake that don't ever go to the other side of the lake because they can't.
Correct.
There's no bus route.
Correct.
There's no way to get there.
Or they can't take off from work.
They can't leave.
They have a sick wife, a sick mother. They 100%. Just can't get there. I was the only one.
Wow.
Right. And so when I was, again, just in the center of New Orleans, because, we had Medicaid transportation and we did have a couple of satellite clinics and places that we would go.
Right.
I thought that we were killing it, right? I thought that we were providing care. And when I went there, it was heartbreaking and sobering to know that there's so many people that couldn't get there.
Fall through the cracks.
So I acted almost like a triage center. So I said, send me all of the adults, whether it was hematology or oncology related, and I would try to see them and go, okay, ma'am, sir, you really need to get over there. And do a warm transfer, right? I would pick up the phone and call the colleague and say, I have Mrs. Brown here. She has anemia. That's why she came to me, but it really looks like she has stage 4 colon cancer. She needs to come today. Right. And we would send her. Now, did that lady have to have stage 4? Colon cancer?
Wow.
Right. So it's those types of things.
Right.
And again, this extrapolates and applies to people living with rare bleeding disorders. And it certainly applies to people who are living with mild and moderate hemophilia, including women and girls, like these same types of issues. So when we're fighting for things for people living with rare diseases, there's so many people, right, that we're trying to include. When we're fighting to have care for people who live rurally,
right,
that could really change the face of America, right? But I didn't know that existed.
Right. Right. Right.
I thought we were killing it.
Right.
Like it wasn't a part of my stratosphere.
Well, you only know what you know. I mean, and honestly, that's so progressive comparative to a lot of other states.
It is.
It's so progressive. So you are better than a certain number of folks.
It is.
But
yeah.
But at the same time, does that mean you're meeting every need? No one can meet every need.
No.
I think that this is the thing too, is that this is part of having grace for all of us, because we're all on a journey. And while we know a lot, we still don't know everything.
We don't know everything.
And the reality is that there are probably, many things that we need to change and do. And it is about the satisfying the fire really in the house that's burning down first, and then prioritizing. I actually have the chairman of our board used to work for an nonprofit organization that did disaster response and relief. And one of the things they did especially through Hurricane Katrina, was sort of disseminating resources to these really tragically, difficult damaged areas. One of the factors that he used to say was, he said, one of the problems that, everybody was mad at FEMA for a while. And it was like, he said, one of the problems that he realized was that FEMA was very methodical about what they did. And their mission was to manage a crisis. And he said, the problem is you can't manage a crisis. He said, you have to just respond.
Right.
When there's a crisis going on, you just respond. But it is once that crisis is now settled that then you can sort of manage some of the ancillary phase 2, phase 3 of the recovery. And I feel like in American healthcare, like in North America, for our healthcare system, there are so many people, whether it be cancer, whether it be hemophilia, whether it be all of these things, we were so focused on just having any solution. And some of those solutions created their own sense of challenges. And yet now we're getting to a phase where some of those things can calm down a little bit. I think right now we still have quite a few things that need to be addressed from a policy point of view as it pertains to the insurance and all of that. But we can't just go from one crisis to the next. I do feel like overall we are seeing some progress. The problem is many of us feel like it's too slow and it's not fast enough and all this stuff. But if we can give each other grace and still speak up for ourselves and speak up for others,
right,
and really keep looking until we find that compatibility with a provider, when we find that compatibility with and sometimes look, people will drive forever to go find, the right person. And with telemedicine, that's an element that sort of opened up a window. I don't think that that's the long-term solution, but there are ways that those types of tools, I think, that we can gain, just like this conversation today is being streamed and broadcast to thousands of people all over the place. And that was never even possible.
That's right.
Even just 10 years ago, this wasn't a normal thing.
It was not a thing.
Yeah. So there's probably people listening to this today that are going, oh my gosh, I didn't even know that there was somebody out there who really understood what I was going through.
Yeah.
And so anyway, I just want to say that I'm applaud seems like too small of a word, but I'm so grateful for all the work that you've done and all of the empathy that you've had.
I appreciate
and it starts
that.
with just caring for one.
It does.
And it starts with just embracing your calling, which you've done. And simultaneously, I think what many people miss, and I'm going to say this to all the patients that are listening right now, I think what oftentimes we miss is that in a crowd of difficulty, sometimes it just takes a spark of one person
That's right.
to champion it that makes progress for the whole. Rising tides lift all ships. If you can just rise above it for just a minute in the emergency room, in that one-on-one conversation, you think it's just you and that. But today, you and I are having just a one-on-one conversation, but there's thousands of people. It could maybe potentially elevate the conversation for the whole community. And this is what I want to say to all the patients who are listening to this. It's so important that you get this, is that your diligence to stay on task, to continue seeking answers for the challenges that you've had, and looking for the right partners and the people to join forces with in your healthcare team is not just going to fix a problem for you, but it could fix a problem for generations to come in your family, but for the whole community.
Absolutely.
You've done that. You're people are going, oh, we better pay attention because Tammy's going to tell us how it is.
Yeah.
But really every one of us as people living with it are also this, we were talking about just before we started the recording about how some of us are trained for this.
And some of us are trained by this.
And what's really magical is when you have people like you in our corner that have been both. You've been trained for it and by the community that you've served. And so thank you so much, really, from the bottom of my heart. And I know I say that on behalf of thousands of people that have said the same thing. So we appreciate all you do. And keep it up, because we need more of it. And we'll be following you closely to see what we can do next. So thank you so much.
Thanks for having me.
Thanks so much for joining us with this podcast today. I certainly hope that you enjoyed this. I know I learned a lot, and I think that you did too. Fascinating enough, I actually took notes today. I have some things that I took some notes on, and I don't always do that. So this is really helpful and inspiring to me, but I hope it was helpful and inspiring to you too. And if you have any questions, or if any thoughts come to mind that you go, man, who do I go to? Where do I go? I don't even know what my next step should be. Don't hesitate to reach out to us. We're real people with a real office, with a real team of people. There's 15 of us around here trying to help people every day. And one of the things we do is love to help you as you are on your journey. So if you need that help, you can always call us, 888-529-8023, or you can email us at info@hope-charities.org. We would love to be able to serve you in any way that we can. Thanks for listening in today, and I look forward to seeing you on the next one. So take care.